मेरा नजला और मतलब बलगम ना कीड़ा न जाता ना मुंह कीड़ा जाए, सब गले में उतरता रहे।
अच्छा, कब से ये गांठ कब से है गले में?
ये सबसे ज्यादा मतलब जब से दिखाई दी है ये
1 महीना हुआ?
ना,
और
ये जब से ज्यादा मतलब एमसी ज्यादा आने शुरू हुई है ना, मतलब ज्यादा
2 महीने 3 महीने कुछ तारीख तो 7-8 महीने हो गए। अच्छा, तो आपने गांठ कैसे देखी गले में? कब से? 8 महीने पहले आपने खुद देखी या किसी ने बताया?
मतलब मुझे खुद मालूम है कि गांठ है अंदर इसके, बलगम चल रहा है।
नहीं बलगम छोड़ो ना, ये ऊपर से जो दिख रही है,
जो ऊपर से तो कमजोरी से दिख रही है कि क्या नाम की पहले की ये गांठ की बहुत दिनों की।
कितने महीने से है
ये तो मतलब शादी हुई हुई है, तब से गांठ पड़ी है।
अच्छा, तभी से है।
हाँ,
कहाँ की रहने वाली हैं आप?
सारी गांठ है, ये तो
रहने वाली कहाँ की हैं आप?
के पास में
हैं?
बैजूई के पास में,
बेजोई मतलब मुरादाबाद के पास है?
बैजूई के पास में संभल जिला है।
कौन सा जिला?
संभल जिला।
Sambal. Actually, what I am trying to take in this history is the endemicity of a goiter is in those areas where the say foothills of Himalayas and most of the hilly areas the patient has low iodine content, and in these areas there is epidemic and many patients may be suffering from this type of pathology. आपके घर के आसपास के किसी लोग को भी गले में गांठ है इस तरह से? She is from Sambal, which is also not very far off from Muradabad and other areas, which is also in the foothills of Himalayas. So endemically she is there, and she says that it is for many years. So this goiter is there and she was not aware of it. Recently she says there is some difficulty in swallowing or anything, which has prompted her to come here and show the case. So now अब इसमें गले में जो आपको गांठ है, इसमें कोई दर्द होता है, कोई तकलीफ होता है?
कुछ ना।
हाँ, फिर क्या?
जब सब हो जाए ना तो थूक निकलने में,
थूक निकलने में परेशानी होती है।
हाँ, मतलब
तो डिफिकल्टी इन सॉलोइंग है, बट इट इज पेनलेस स्वेलिंग, है ना? और इसके अलावा आपके हाथ पैर कुछ कांपते हैं, कुछ और कुछ कहीं पे गर्मी ज़्यादा लगती है, या कोई इस तरह का कुछ मौसम के हिसाब से कुछ फर्क पड़ता है, या जैसे पहले था वैसा ही है?
मतलब कुछ ज़्यादा मौसम के हिसाब से तो बाई टाइम पे छोटे
सर्दियों में ज़्यादा परेशानी होती है।
सर्दियों में ज़्यादा परेशानी?
तो ज़्यादा परेशानी है।
अच्छा, पसीना तो नहीं चलता बहुत ज़्यादा इनका?
नहीं, पसीना ऐसे ज़्यादा तबीयत खराब होती है ना, इसी के गलों पे ना आता है ना कीड़ा।
Okay, so first of all we must understand that in any goiter or any thyroid swelling, there are three types of lesions. One is a lesion in which there is thyrotoxicosis. The other lesion is neoplasia, and third is the thyroiditis. So these are the three types of pathologies you generally get. Either it is hypothyroid or hypothyroid, hyperthyroid or hypothyroid. So if it is hyperthyroid, it is thyrotoxicosis. If it is hypothyroid, then it is there is swelling of the face and all. It is just the reverse of thyrotoxicosis. So that has to be seen. She is a thin built lady, and she does not have that obese face or all those faces. So it is very unlikely to be from hypothyroid. So now we will have to focus on a thyroid which has either, and in this age it is more likely to be neoplastic. So I told you the three types of thyroid. One is having either thyrotoxicosis or hypothyroid state. Second is it can be neoplasia, which can be benign or malignant, and the third one is thyroiditis, which is generally an autoimmune disorder. So now the most common presentation in this age is suspected to be a neoplastic disorder. So neoplastic disorder we have to consider, and accordingly we have to proceed with the examination. So in the examination, of course in history you have to ask whether patient has tremors or sweating or preference to cold. So all these things have to be taken because that points out towards the toxic or non-toxic state. Then since this is for a long time, in a case of thyrotoxicosis also, there are two types of thyrotoxicosis. One is Graves' disease and one is secondary thyrotoxicosis. So in Graves' disease, the disease and the thyroid appear simultaneously. And in secondary thyrotoxicosis, the thyroid is there for a long time and symptoms of thyrotoxicosis supervene later. So if this was a case of toxic goiter, then in this case it would be a secondary thyrotoxicosis because the patient had a thyroid swelling for a very long time. So now if toxicity symptoms, which includes tremors, tachycardia, cardiac diseases, that we will have to assess on examination. Right now I am telling you the history that there are two types of thyrotoxicosis. One is primary and the second is secondary. The primary is also known as the Graves' disease, which is autoimmune, and it is both the signs and symptoms of thyrotoxicosis appear at the same time along with the goiter. Whereas in secondary thyrotoxicosis, there is a pre-existing goiter and then the signs of toxicity supervene. The other difference is that neurological features are more common in primary thyrotoxicosis, whereas cardiac symptoms are more common in secondary thyrotoxicosis. So when we are evaluating the patient on examination, we have to focus on these things. That neurological means tremors, and patient may be fidgety, patient may be not very sitting comfortably in the seat, she may be moving one place to the other, and there are so many changes, and there's increased hyperreflexia is there, so and pretracheal myxedema is there. So these are typical features of primary thyrotoxicosis. In secondary thyrotoxicosis, the burnt of the effect of the hormones is felt on the cardiac system. So there can be tachycardia, there can be extrasystoles, and there can be congestive cardiac failure. So if the patient has secondary thyrotoxicosis, major part is in the cardiac system. That is about toxic disease. But I told you in this patient we are suspecting a neoplastic lesion. So we have to focus on that. Now again, the neoplastic lesions are various types, so we will have to see first on the examination. So now अब इधर मेरी तरफ घूम जाइए. हाँ. अब on inspection, you have to say that the patient थूक सटकिए. So you have to take the pulse. That's very important. Then you have to see for tremors. हाथ खोलिए आगे. ऐसे पूरा हाथ. ऐसे खोलिए. इस पर रखिए मत. Mild tremors लग रहे हैं, but this could be anxiety also. So it's not necessary that the tremors are there, but there is some flickering movement of the fingers. So that is there. You just count the pulse. Come here, this side, for 1 minute. Or with watch. Then you have to see for pedal edema. पैर दिखाइए. There is some pitting edema. You see on the other side also. There is pitting edema. So she has, and of course, नीचे देखिए. No icterus. ऊपर देखिए. No pallor. And of course lymphadenopathy. There is no lymphadenopathy. So now we will focus on the thyroid swelling. On inspection, you can see there is. How much is the pulse? There is a swelling in front of the neck. Confined 90 is the pulse. So there is a swelling in the front of the neck which is moving with deglutition. and this is about 2.5 into 3 centimeters. 2.5 is the lateral transverse and 3 centimeter is the vertical. So this is moving with deglutition. Left side, the lobe is actually, the thyroid swelling is a butterfly shaped swelling where you have the isthmus and the two lobes. So if you see this swelling during deglutition, it is the left lobe is negligible, not visible so much, but the right lobe and the isthmus is prominent, and this is forming a single mass. So this is a single mass which is visible and involving the right side and the isthmus. Acha, oh, that we'll see. Good job. Now on palpation, you have to do two types of palpations are there: classical method and in this case Lahey's method. So what is Lahey's method? We'll do the Lahey's method. Gardan chukaiye, and I'm pushing it from this side, and I'm palpating this lobe. On the other side, the back of the lobe is also palpable. So I'm confirming the findings for inspection. Anybody has got a tape? Scale hai? Scale लाइए. Now this, with the scale, we will measure the exact extent of the swelling. It is 4.5 centimeters vertically and around 4 centimeters transversely. So it is an oval swelling, 4.5 centimeters, and you can see that part of the swelling is under the sternocleidomastoid. And when I am putting my finger and asking her to deglutate, it is moving up with deglutation. And my finger can be insinuated on the left side because that part of the lobe is negligible or not seen, not felt. But here it is difficult to insinuate the finger because this part is bulky and larger. So skin is free and it is mobile and it is non-tender, but it is hard in consistency. And multiple hard nodules are palpable in the skin. So that shows that this could be a neoplastic lesion. So there is size is 4.5 and 4 centimeters, oval in shape, and it is mainly confined to the right side and the isthmus, and left side is absent, and it is hard in consistency. Suprasternal notch is free, so the swelling is not going into the thorax, and not retrosternal extension is not there. And then you have to palpate the lymph nodes to see whether the lesion is extending to the lateral part of the lymph nodes, jugulogastric, jugulo-omohyoid and supraclavicular. These lymph nodes are not palpable, and there are no other lymph nodes which are palpable clinically. So the only finding which is very, some of you come, just palpate this. Just feel the swelling. It's very hard, stony hard almost, and multiple nodules are there. Yes. See? So this is a typically solid swelling and 4 into 4.5 centimeter in size, and it is moving with deglutition, and गुला सूख गया ना, अभी पानी पिलाएंगे आपको, रुक जाइए. Carotid pulsations are felt, they are in the normal position. You don't feel both the carotids simultaneously. And पानी है? पानी. So now we conclude the history and examination. This lady came to us with a history of a pre-existing swelling for many years, and recently she has started having some discomfort of, that is, difficulty in swallowing, and the swelling has not enlarged too much, but it is causing some discomfort, and there are no tremors, and the tachycardia is also not there. So it doesn't look like to be a thyrotoxic swelling. And on palpation, there is oval swelling which is 4 into 4.5 centimeter, and it is hard in consistency, and it is not confined to the neck. Most of the swelling is confined to the right lobe and the isthmus, the left lobe. So you can also call it a solitary thyroid nodule. Solitary thyroid nodule. Why? Because the whole swelling is single swelling and rest of the swelling is not palpable. So sometimes you get a question in the examination, what is a solitary thyroid nodule? So this is likely to be a solitary thyroid nodule. So the differential diagnosis of solitary thyroid nodule is, it can be a benign lesion or it can be a malignant lesion. Papillary carcinoma, follicular carcinoma, medullary carcinoma, and a plastic carcinoma. So these are the 4 possibilities. अच्छा अभी अम्मा अभी देखते हैं, अभी बताते हैं. ठीक है. तो with the clinical finding, hard swelling, non-tender, and affecting the swallowing. So when the thyroid enlarges, it can cause pressure over the recurrent laryngeal nerve. It can cause pressure over the esophagus, and of course the appearance also changes. हमारा रोने की ज़रूरत नहीं है. So now this patient has come to us and we have made a diagnosis of a solitary thyroid nodule, probably neoplastic and malignant neoplasm. So now the next course would be to confirm the diagnosis. So the confirmation of the diagnosis is by the typical method: clinical assessment, radiological assessment, and pathological assessment. So in the clinical assessment, we have already done the clinical assessment and we have concluded that it is a hard swelling, which is and having multiple nodules also. So most likely it's a malignant nodule involving the right lobe and the isthmus. So now you have to go for pathological assessment. So for pathological assessment, before that we like to do a radiological assessment. So ultrasound of the neck will show how many nodules are there and which is the largest nodule, because you have to take a FNAC from the suspected area, and that is the focused ultrasound has to be done to isolate, because the multiple nodules. So if you put a needle in and you go to the round nodule which is not neoplastic, then you will get a benign lesion. So under ultrasound guidance, so FNAC should be ultrasound guided and focus on the largest nodule which is likely to be malignant. So once that is there, then you will get the histopathology, cytology report, and accordingly you will say it is benign or malignant. Then the third thing is, you will have to do, say, supposing it is malignant, then you have to assess the extent of malignancy. So you have to do the staging. So clinically lymph nodes are not palpable, but radiologically they may be palpable. So you have to, maybe you have to do a CT of the neck, and also you see metastasis from the thyroid goes to bones very commonly. So you have to scan the other bones, or even sometimes you need to have a PET scan also. So that will tell us the whole spectrum of the pathology, and then you decide about the management. So now supposing this is a malignant nodule, so what treatment is advocated in this case? So follicular carcinoma or papillary carcinoma, now for any malignant nodule, the treatment is total thyroidectomy with lymph node dissection. So we have to do a total thyroidectomy in this lady with lymph node dissection. Previously it was cherry picking operation for lymph nodes, but nowadays complete neck dissection has to be carried out, and in this age I think that would be needed, because we think that the metastasis is there in other organs also, but unless and until we completely evaluate this patient, we cannot say for sure what is the status. So this patient also has come to us from a very poor background, and she is not having money for say treatment, etc. So we will admit her and just do the assessment, And once we know the diagnosis by FNAC and also the stage of the disease, we'll proceed to the treatment. So you have understood how to make take a history, how to do a clinical examination, how to make a diagnosis, and how you treat. Thank you. ठीक है.